Hello guys, my name is Ahana Chattopadhyay and today I am going to start a topic called the upper limb muscles. Uh, Now, I'm not going to end this topic today, I'm just going to start this topic and what I'll suggest is that you may take, you may take notes while watching this video, or you may write down the things because it will help you remember the things better or in a more enhanced way. The more you write, it will be more helpful for you. Now I'm going to, this was just a suggestion, so now I'm going to start my topic. Now, introduction. Basically, the muscles of the upper limb, they can be grouped into two groups. The muscles that attach the limb and the girdle to the body, and the muscles of the arm, forearm, and hand. Basically, the second group is strictly speaking the upper limb muscles in the truest sense. Now, the first group consists of muscles which attach the upper limb and the girdle means here the pectoral girdle or the shoulder girdle, okay, to the body, to the vertebral trunk, to the vertebral column, to the trunk, or to the anterior thoracic wall. So, what do we mean by the pectoral girdle? You must have been taught in osteology. It consists of the clavicle and the scapula. So the clavicle is attached or is articulated to the scapula at its lateral end with the acromion process of the scapula via the acromioclavicular joint, and the clavicle and the scapula together. The clavicle is articulated with the manubrium sterni anteriorly. Okay, so this completes the pectoral girdle anteriorly, but the pectoral girdle is basically incomplete posteriorly because there is no such bony articulation of the scapula or the clavicle posteriorly. So today I'm only going to talk about these muscles. It is a group 1 muscles that attach the limb and the pectoral girdle to the body or the vertebral column. Now, the muscles of arm, forearm, and hand, I'm going to discuss it in my next class. So now the group A muscles can be further subdivided into two more groups. The first group consists of muscles of the shoulder region, such as the trapezius, the levator scapulae, and the rhomboids, which connect the scapula and or the clavicle to the trunk. Here the trunk means we can say the vertebral column. It will be better for you to remember. Now these muscles are not of so much importance for you people. They have multiple sites of origin and the origin might be difficult for you to remember as of now, but the insertion you may come across or you will come across while studying the bones of the upper limb or the osteology part. For example, the trapezius gets inserted in the lateral 1/3 of the clavicle, the anterior surface, basically anterior surface and upper surface, also some areas. Levator scapulae, it's inserted into the medial border of the scapula to the dorsal aspect. Rhomboids also. The rhomboidus minor and the rhomboidus major. They get inserted onto the medial border of the scapula, onto the posterior aspect of the dorsal surface of the scapula, if you can say. Now, I just elaborated the insertion for your benefit, but now I'm going to shift to the next subclass or subgroup of this group A muscles, and these muscles connect the clavicle, scapula, both or any one of them, and the body wall to the proximal or the upper end of the humerus. These include the pectoralis major, pectoralis minor, larissimus dorsi, teres major, and deltoid. Now, all of these muscles, or most of these muscles, are quite important for you. For example, pectoralis major is quite important. Deltoid is very important for you guys. So, now the most important important of these group of muscles are the four rotator cuff muscles. Now, what is the rotator cuff? I'm going to touch upon that or come upon that later on in this video. But for now, just remember four muscles form the rotator cuff, four very vital muscles. You can remember the mnemonic SITS or SITS, subscapularis, supraspinatus, infraspinatus, and teres minor. These four muscles form the rotator or the musculotendinous cuff, which connects the scapula to the humerus, and basically they provide stability or support to the shoulder joint, strictly speaking the glenohumeral joint, and it is very important basically because when you will come to know that the shoulder joint, the most vital form of shoulder joint dislocation is inferiorly, because the rotator cuff, it provides support anteriorly, superiorly, posteriorly, but inferiorly as such the shoulder joint has got no such support. So inferior dislocation of shoulder joint is quite common. Now here you can see the muscles here. You can see that here is the trapezius. This is the levator scapulae. This is the rhomboideus minor. This is the rhomboideus major, and this is the deltoid. So here you can see the levator scapulae is inserted onto the, we can say medial border. It will be better to say the superior angle of the scapula here, close to the medial border basically, but on the dorsal surface or the dorsal aspect. Now the rhomboideus minor and the rhomboideus major. Rhomboideus minor is inserted onto the medial border of the scapula on the dorsal surface or on the posterior surface, just nearby to the crest or spine of the root of the spine of the scapula, as we say. And the rhomboideus minor, major, it is inserted again, as we can see here, medial border of the scapula, posterior aspect or the dorsal surface, but below or inferior to the root or this of the spine of the scapula. Trapezius, you can see it has a conjoint insertion here. You can see that it is inserted onto the acromia process. This is the spine of the scapula, so upper lip of the spine of the scapula, crest, and then acromia process, medial or upper lip, and then here it will be attached or inserted to the lateral one third of the flap. Here you can see the pectoralis major muscle. It has a clavicular head and it has a sternocostal head. This is a deltoid muscle. This is the serratus anterior muscle, again a very important muscle for you guys. I am going to touch upon that later on in this video. So let's move on to the next slide. Now the rotator cuff muscles, as I say, this is very important for you. Shoulder joint can come as a long question. Nowadays it's 15 marks. I think it will be taught separately in another class, the joints. There also you will come across this rotator cuff thing. It's very important, as I am repeatedly saying. It may come as a short note or as a MCQ question also. So enumerate the rotator cuff muscles also. It can come in this way. Now, introduction continued. I'll just say a little because I'm going to tell about this in my next class. This is basically about the upper limb muscles in the truest sense. It is saying that muscles in the basically the upper limb muscles, for our own convenience, we divide the upper limb into arm, forearm, and hand. Again, arm can be divided or is divided into an anterior and posterior compartment. So on what basis do we divide this anterior and posterior compartment? Okay, basically the anterior compartment of the arm, I'll just shift basically to the next picture. This will be easier for you to understand. You can see that here there is a lateral intermuscular septum and here there is a medial intermuscular septum. This is the humerus. So the muscles that are present in front of this, these are the, we can say, anterior compartment. These muscles comprise of the anterior compartment. This is this is the muscle of the posterior compartment, basically triceps brachii. It has 3 heads. So behind this, the separation thing, which is formed by the lateral intermuscular septum, the humerus, and the medial intermuscular septum, they divide the arm into an anterior and a posterior compartment. And this is the deep fascia, continues with the deep fascia. So similarly, if you see the forearm, here we'll see that laterally there is this lateral intermuscular septum. There is a radius, then there is an interosseous membrane between the radius and the ulna, and this is a ulna. So the compartment which is present in front of this partition, this is the anterior compartment, and I'll tell about the muscles of the anterior compartment of forearm in my next class. And the muscles which are present posterior to this, this partition is basically the muscles of the posterior compartment of the arm. So basically this is written in words in this slide, where it is elaborated that the anterior compartment of the arm lies anteriorly in position, separated from the muscles of the posterior compartment by the humerus and by the medial and the lateral intramuscular septa. Now, medial and lateral, I hope you guys know these terms. Medial means towards the body, lateral means away from the body. So these intermuscular septa are in turn continuous with the deep fascia. In the forearm, the anterior and posterior compartments are separated, as I just now explained to you with the help of the diagram, with the help of a lateral intermuscular septum, the radius, the ulna, and an interosseous membrane, which joins the adjacent sides of the radius and ulna. Now, I'm just elaborating. I'm not going to elaborate. I'm just mentioning a little that in case of upper limb, the muscles which are present in the anterior compartment of arm or forearm, they are basically flexor muscles, or they help in flexion. Whereas the muscles which are present in the posterior compartment, they help in extension. But this is not the same in case of lower limb, because of the developmental origin rotation takes place. So in lower limb, the muscles that are present in the anterior compartment, they are always extensor muscles, and the muscles which are present in the posterior compartment, they are flexor muscles. So you should remember this basic thing, the difference between the lower limb and the upper limb. And basically this is what here it is written, that here anterior flexor and posterior extensor compartment, that is what is meant by that. And the muscles of the arm, they basically move the forearm at the elbow joint. This is the elbow joint. And the muscles of the forearm, they move the hand at the wrist joint, and also the fingers and the thumb. Muscles of the hand, basically they're intrinsic muscles, and they help in delicate movements of the digits of the hand. So they help in precision grip and other grasping and other functions. So delicate movements basically. Now I'm just going to say a little about the movements. This is a picture of the movements, the various movements that take place across the shoulder joint. Now here you can see flexion and extension. Flexion means the arm is moving medially and forwards, whereas extension means the arm is moving, basically the hand is moving backwards and laterally at the shoulder joint. Now it occurs at a plane which is parallel to the glenoid cavity, midway between the sagittal and the coronal plane. I hope you guys know about the sagittal and the coronal plane. The sagittal plane, it passes to the sagittal suture, and basically sagittal plane here, sagittal plane can be of two types: mid sagittal plane, which passes through the sagittal suture, and parallel to it there can be many other, parallel to the mid sagittal suture there can be many other sagittal planes. And coronal plane is a plane, only one coronal plane, which passes through the coronal suture of the skull. So here also you will see that other movements. This is abduction and adduction. Abduction means the arm is moving laterally away from the body, and adduction means moving posterior medially towards the body. Medial rotation and lateral rotation in case of the shoulder joint is best seen when we mid flex, or the elbow is kept, or the upper limb is kept in a mid flex position. The elbow is in a mid flex position. Medial rotation means the limb is moving medially towards the body. Laterally means laterally away from the body. Now, circumduction is basically a combination of all these movements. All the movements, if integrated together, form circumduction. Now, flexion, abduction, extension, and adduction. These 4 movements, if we combine them, gives rise to circumduction. So this is a picture of the movements that is taking place across the shoulder joint. Now, muscles of the pectoral region. So now we come to the main topic. The pectoral region is basically, or chiefly speaking, the anterior aspect of the thorax or the chest. Muscles of the pectoral region consist of muscles that connect the upper limb with the anterolateral chest wall. So here, what are the pectoral region muscles? There are 4 in number: Pectoralis Major, Pectoralis Minor, Subclavius, and Serratus Anterior. Now, strictly speaking, or I'm saying in a much simpler way, that Serratus Anterior is not a muscle of the pectoral region, but it is a muscle of the thoracic wall. Okay, it clothes the thoracic wall, but for convenience, it is being described with the muscles of the pectoral region, and also because it connects the thoracic wall to the scapula. Now, among these 4 muscles, Pectoralis Major and Serratus Anterior are the most important for you. Subclavius is not at all important. Pectoralis Minor, if you can remember, especially for its various attributes, like it helps in demarcating the various parts of the axillary artery, as you will come to know later on. You can remember Pectoralis Minor. If you remember, it will be good for you. So now we come to Pectoralis Major. Now, if we perform a dissection of the pectoral region, we will see that the first layer that we come across is the skin. If we retract the skin, then we come across a superficial fascia. If we retract the superficial fascia, we come across basically the fascia that is covering the pectoralis major muscle, which we call the deep fascia. Then we come across the clavipectoral fascia, which covers the pectoralis minor muscle, and then the pectoralis minor muscle. So the pectoralis major muscle, if we talk about the muscles, then the most superficial muscle is the pectoralis major in case of the pectoral region muscles. When we are talking about the pectoral region muscles, pectoralis major is the most superficial of all the muscles of this region, and it is also the largest muscle of this region. It directly underlies the breast, and it is separated from the breast by the deep fascia and the loose connective tissue of the retromammary space. Retromammary space means mammary gland is here, the breast, and behind the mammary gland. Retro means behind. So loose connective tissue of the space that is present behind the breast is called the retromammary space. So it's a large, thick, fan-shaped or triangular muscle, and it arises by 2 heads: small clavicular head and large sternocostal head. So now we come to the origin of pectoralis major. If you see the clavicular head arises from the medial half of the anterior aspect of the clavicle, or better to say, if I say in this way, it arises from the anterior surface of the medial 2/3 of the clavicle. While the sternocostal head, it arises from the lateral half. When you study sternum, you will see pectoralis major is a very important relation of the anterior surface of the sternum as well as the mandibular sternum up to the 6th costal cartilage. Again, it has basically 3 origins of the sternocostal head. It also arises from the medial parts of the 2nd to 6th costal cartilages. And third origin is from the aponeurosis of the external oblique muscle. External oblique muscle you will study in abdomen. It is one of the 3 flat muscles of the abdomen. External oblique, internal oblique, and transversus abdominis. So basically, now pectoralis major, we come back to pectoralis major. Its sternocostal head has 3 origins, as you can see here. Now insertion. It will be easier for you to remember. Later on you will see a picture. Maybe there is a picture I'll show you later on. Insertion of pectoralis major, it gets inserted into the lateral lip of the intertubercular sulcus or bicipital group of the humerus. The bicipital group is a feature of the upper end of the humerus head. Basically, the pectoralis major is inserted onto the lateral lip of this bicipital groove. Now, there is a mnemonic which we call lady between 2 majors. So, lateral lip, there is insertion of the pectoralis major. Medial lip of the bicipital groove, there is insertion of the teres major muscle, and in between them, in the floor, there is insertion of the latissimus dorsi muscle. Okay. So now, what is the manner of insertion of this pectoralis major muscle? It has a flat U-shaped bilaminar tendon, 2 lamina, bilaminar tendon, U-shaped. So the anterior lamina, if this is a U, okay, this anterior lamina is formed by the clavicular fiber, and the posterior lamina, okay, you can see this is a posterior lamina. It is formed by the sternocostal fibers, and these 2 lamina are continuous inferiorly. Okay. So action. Again, you will understand this very well when you study the shoulder joint also, where you have to remember the various muscles which are responsible for the various movements that are taking place across the shoulder joint. You will see that the clavicular fibers of the pectoralis major, they help in flexion of the arm and the shoulder joint. Whereas a sternocostal head, it is principally the adductor and medial rotator of the arm at the shoulder joint. Nerve supply. I think nerves of the upper limb will be taken in a separate class, where you will see that all the major nerve supply of the upper limb muscles comes from nerves of the brachial plexus. It is very important, the brachial plexus, for you to understand all the nerve supplies. So here the nerve supply is by the lateral and the medial pectoral nerves. The lateral pectoral nerve arises from the lateral cord of the brachial plexus, whereas the medial pectoral nerve arises from the medial cord of the brachial plexus. So, clinical testing, you can just go through it. It's not so important. You can remember or not remember it. Clinical correlation, I'll just touch through this topic. Sometimes there is a congenital anomaly of the pectoralis major muscle, where usually the sternocostal part is absent at birth. So if the sternocostal part is absent, then the function of the sternocostal part will be affected, obviously. So there will be weak adduction and medial rotation of the arm. Okay. So this is a picture of the pectoralis major muscle. This is the clavicular head. As you can see, it takes origin from the anterior surface of the medial 2/3 of the clavicle. This is the sternal head. It has multiple origin from the anterior surface of the sternum laterally, then from the medially from the 2nd to 6th costal cartilages, from the aponeurosis of the external oblique muscle. It is inserted onto the lateral lip of the bicipital groove. Here also it's very clearly given origin clavicular head from the medial 2/3 of the clavicle. This is origin of the sternocostal part, and this is the insertion into the lateral lip of the bicipital groove. So I was talking about this congenital anomaly of pectoralis major muscle. This is the Poland syndrome. It's a very rare syndrome where we see partial or complete agenesis. Agenesis means there is a developmental anomaly. During embryogenesis, there is some basically problem in the formation or the development of this pectoralis major muscle. So there is a partial or complete agenesis of the pectoralis major muscle, and it occurs um, either alone or with ipsilateral. Ipsilateral means same-sided. Okay, same-sided hand abnormalities and various degrees of breast and nipple aplasia, as in Poland syndrome. So this is a congenital anomaly of the complete agenesis of the pectoralis major muscle. So this is the insertion pattern. As I said, the mnemonic lady between two major. The pectoralis major muscle is inserted in this lateral lip of the bicipital groove. Okay, and the medial lip there is insertion of the teres major muscle, and latissimus dorsi is inserted in the bicipital groove. It is a little wrongly given in this diagram, but it will be inserted here in the bicipital groove. Okay, and teres major muscle will be inserted into the medial lip of the bicipital groove. Now we come to the pectoralis minor muscle. It's a small triangular muscle which we will basically, if we retract the pectoralis major muscle, then only we'll come to the pectoralis minor muscle. Okay, so it lies deep to the pectoralis major muscle. It lies deep to the clavipectoral fascia. Its origin is from the third, fourth, and fifth ribs near their costal cartilages. So near the costochondral junction, the junction between the ribs and their cartilages of the third, fourth, and fifth ribs, the pectoralis minor takes origin. It is inserted by a short, thick, flat tendon into the medial border and upper surface of the coracoid process of the scapula. You just remember the coracoid process of the scapula. If you can remember the medial border and upper surface, very nice. Okay, it'll be very good. But remember the coracoid process of the scapula. Nerve supply again by medial and pectoral nerves. Medial pectoral nerve serves by, supplies the muscle by piercing the muscle. Actions. As I said, serratus anterior is a very important muscle. I'm going to talk about that later on in my slide or in my class. So, pectoralis minor muscle, it assists the serratus anterior in drawing the scapula forward for punching action. Okay, punching action. This, action of the scapula, it gets rotated in front. Okay, this is called protraction of the scapula. Other two minor functions is it depresses a point of the shoulder inferiorly like this. Okay, this. So acts as an accessory muscle of respiration also in forced inspiration. Now, as I said before also, pectoralis minor muscle is called as a key muscle of the axilla as it divides the axillary artery, which is a continuation of basically the subclavian artery only, as it crosses the inner surface of the first rib. Okay, or no, the outer surface of the first rib. The pectoralis minor is considered as a key muscle of the axilla as it divides the axillary artery into three parts. Okay, the second part lying just behind the muscle. So the second part of the axillary artery lies just behind the muscle. First part lies proximal to the pectoralis minor, and the second part lies distal to the pectoralis minor. When you will be taught about the blood supply of upper limb, you will obviously read about the axillary artery. The origin of pectoralis minor is variable. Okay, so it may be prefixed, that is, it arises from the second to fifth ribs, or postfixed, that is, it arises from the fourth to sixth ribs. Okay. Now, really, some fibers of the pectoralis minor separate and pass from first rib to the coracoid process to constitute what is called the pectoralis minimus muscle. So here's the pectoralis minor muscle. You can see it takes origin from the third, fourth, fifth costal cartilages, gets inserted onto the coracoid process, medial border and upper surface. Here it is shown in a much more, clear way. So here I was talking about the clavipectoral fascia. If I touch upon this sagittal section to the pectoral region, clavipectoral fascia splits and encloses the pectoralis minor muscle. And superiorly, it again splits to enclose the subclavius muscle. But inferiorly, this portion, it basically becomes continuous with a suspensory ligament of the axilla, which is responsible for forming the dome of the axilla. Okay, it stretches the dome of the axillary sheath. So subclavius muscle, it's not so important for the exam purpose also. It's a very unimportant muscle. It's a small muscle which is directly underneath the clavicle, lies. It is present horizontally, and it affords a minor protection to the underlying neurovascular structures. It arises from the first rib at the costochondral junction. Insertion is in the subclavian group, which is a feature of the inferior surface of the middle two-thirds of the clavicle. Nerve supply is by the nerve to subclavius, which arises from the Erb's point of the brachial plexus. Basically, you will study about it in detail. It arises from the brachial plexus. Okay, it is a direct branch from the upper trunk of the brachial plexus. So, actions: the subclavius stabilizes the clavicle by pulling it inferiorly and medially during movement at the shoulder joint. This is the subclavius muscle. Very clearly given here in this diagram, in this green colored muscle, which lies horizontally directly underneath the clavicle, is the subclavius muscle. This is the subclavius muscle. Now we come to serratus anterior. Serratus anterior is a very important muscle for you people to remember. It's strictly speaking, it is not a muscle of the pectoral region, but for convenience, it is described with the muscles of the pectoral region. It's a broad sheet of muscle that clothes the side wall of the thorax. Origin: it arises by 8 digitations from the upper 8 ribs. The first digitation arises from both the first and the second rib, whereas the other digitation arises from the corresponding ribs. There is a second digitation arises from the second rib, third from the third rib, fourth from the fourth rib, in this way. But first digitation, it arises from both first and second ribs. Insertion: it's inserted into the medial border of the scapula along its costal surface or anterior surface. The first two digitations are inserted into the superior angle, next two digitations into the medial border, and the lower 4 or 5 digitations into the inferior angle of the scapula on its costal aspect. Nerve supply, very important, by the long thoracic nerve or the nerve of Bell or the nerve to serratus anterior, which is a direct branch or which is directly derived from the C5, C6 and C7 roots of the brachial plexus. This is very important because of a very important clinical correlation that I'm going to touch upon in my next slide or in my coming slides. Before that, let me elaborate the action of the serratus anterior. The serratus anterior is a very powerful protractor of the scapula. It pulls the scapula forward around the chest wall for pushing and punching movements. Like for this punching action, the serratus anterior muscle is very important, and hence it is called the boxer's muscle. As I discussed earlier, pectoralis minor muscle assists serratus anterior in the protraction function. It keeps, another function of serratus anterior is that it keeps the medial or the vertebral border of the scapula in firm contact with the chest wall. Its lower 4 or 5 digitations, along with the lower part of the trapezius muscle, they rotate the scapula laterally and upwards during the overhead abduction of the scapula. Overhead abduction means greater than 90 degrees. And overhead abduction of the scapula, here especially we are talking about from overhead abduction of the shoulder joint from 120 degree to 180 degree. In this range, the scapula needs to rotate laterally to complete the overhead abduction of the shoulder joint. It has a range of movement from 0 to 180 degree. 0 to 15 degree is done by the supraspinatus muscle. 15 degree onwards, it is carried on by the deltoid muscle till 90 degree. 90 degree to 120 degree, it is dependent on the movement of the humerus laterally also. Okay, and then from 120 degree onwards, it depends on the scapula, its movement laterally on the chest wall. Okay, so this is the serratus anterior. Its origin from the first 8 ribs. First digitation arises from both the first and the second rib, and this is it's boxing action or punching action, hence it is called the boxer's muscle. Now, clinical correlation, very important. In case of an injury to the long thoracic nerve or to the nerve of bell by stab injury or during removal of breast tumor, there may be paralysis of the serratus anterior muscle. So in case of paralysis of the serratus anterior muscle, obviously its very important function, protraction, will be affected. Protraction of scapula is weakened. Next, the inferior angle and the medial border of scapula become unduly prominent when the patient pushes his hand against the wall, producing a clinical condition called the winking of the scapula. As I said before, the serratus anterior helps in connecting the medial border of the scapula with the thoracic wall or with the ribs, in keeping it connected. But if there is paralysis of the serratus anterior muscle, the inferior angle and the medial border of the scapula becomes disconnected from this thoracic wall of the ribs. So when there is this punching action or this boxing action is taking place, the medial border of the scapula becomes unduly prominent, and this feature is called the winging of the scapula. Very important. It often comes as a short note. It came as a short note in our first semester exam, the serratus anterior muscle. And if you can write the clinical correlation, it will obviously yield you more marks. And this is the winging of the scapula. The medial border has become unduly prominent. Now we come to the muscles of the shoulder. The muscles of the shoulder are associated with movements of the upper limb. They produce the characteristic shape of the shoulder and can be divided into two groups, extrinsic and intrinsic. Okay. So extrinsic group, these muscles originate from the back of the trunk, or basically they originate from the vertebral column and attach, or basically their attachment or insertion takes place to the bones of the shoulder, that is clavicle, scapula, or humerus. And the intrinsic muscles, they originate from the scapula and or clavicle and attach to the humerus, also called the scapulohumeral muscles. Now the scapulohumeral muscles are more important from your point of view rather than the extrinsic muscles. Okay. Extrinsic muscles. Now I'll just tell you the names of the extrinsic muscles. As I said, these attach the scapula to the vertebral column, to the back of the trunk, and they're arranged in two layers, superficial, deep. The muscles of the superficial layer are the trapezius and the latissimus dorsi, whereas the muscles of the deep layer are the levator scapulae, rhomboidus major and rhomboidus minor. This is the muscles. This is the trapezius muscle. This is the latissimus dorsi muscle. This is the levator scapulae muscle, rhomboidus minor and rhomboidus major. Now, the intrinsic muscles are quite important from your point of view, especially the deltoid and these four muscles, supraspinatus, infraspinatus, teres minor and subscapularis, which form the rotator cuff. Now, the scapulohumeral muscles, obviously from the name, they connect the scapula to the humerus. You can also connect the clavicle also, basically. But as a term, we call it scapulohumeral muscles because mostly they connect the scapula to the proximal end of the humerus or the upper end of the humerus. These are relatively short muscles which pass from the scapula to the humerus and act on the shoulder joint proper, which is the glenohumeral joint. These intrinsic muscles are 6 in number: deltoid, supraspinatus, infraspinatus, teres minor, teres major, and the subscapularis muscle. Now, deltoid. Deltoid is a very important muscle from your point of view. It is a 3-in-1 muscle. It's a muscle which is thick, powerful, and curved and has a triangular outline. It covers the shoulder like a hood and forms a rounded contour of the shoulder. The deltoid is shaped like the inverted Greek letter delta, hence its name, deltoid. It has 3 parts: an anterior unipinnate part, a middle multipinnate part, and a posterior unipinnate part again. Origin. The deltoid is a V-shaped origin from the subcutaneous bony arch formed by the lateral one-third of the clavicle, the acromia process, and the crest of the spine of the scapula. I'll just see if there is a diagram here. So here you can see it takes origin in this subcutaneous bony arch from this basically three sides. Origin of the anterior fibers from the lateral one-third of the clavicle, origin of the lateral or basically the middle multipinnate fibers from the acromion process, and origin of the posterior fibers from the spine of the scapula. The anterior unipinnate part arises from the upper surface and the anterior border of the lateral third of the clavicle. So the trapezius, it also takes, basically it gets inserted onto the lateral one-third of the clavicle, but I think posterior border. So the middle multipinnate part arises from the lateral margin and upper surface of the acromion process, and the posterior unipinnate part arises from the lower lip of the crest of the spine of scapula. Okay. Insertion. The fibers converge inferiorly to form a short, thick tendon, which is inserted as a V-shaped into the V-shaped deltoid tuberosity, a very important feature of the anterolateral surface of the humerus. Okay, of the shaft of the humerus, anterolateral surface. So the middle acromial part of the deltoid is the strongest part. It goes without saying, multipinnate part. The deltoid is supplied by the axillary nerve, and actions of the deltoid muscle. It has various actions. The anterior clavicular fibers are the flexors and medial rotators of the arm. The posterior spinous fibers are the extensors and lateral rotators of the arm. The middle acromial fibers are the strong abductor of the arm. This is the most important part. Flexion, extension, medial rotation, lateral rotation, abduction. All these are basically said with respect to movement at the shoulder joint. But abduction is a very important movement of the shoulder joint. You have to study about it in detail. Mechanism of abduction is often asked. So the abduction of the shoulder joint from 15 degree to 90 degree is done by this middle acromial fibers of the deltoid. Till 15 degree overhead abduction is done by the supraspinatus muscle. Okay, from 15 degree it is taken over by the deltoid muscle. Now middle acromial fibers cannot, as I said, cannot abduct the arm from 0 to 15 degree. And the deltoid muscle, basically because it has various functions, it is like three muscles in one, 3 in 1. Anterior fibers flex the arm at the shoulder joint. The middle or the lateral fibers abduct the arm, and the posterior fibers extend the arm. Okay. Basically, extension along with lateral rotation and flexion along with medial rotation. Now, this is also very important. The deltoid is a major site of intramuscular injection in deltoid. Intramuscular injection, the COVID-19 injection is also being given in this deltoid only. Other common site is the gluteus maximus muscle also. It is a site of intramuscular injection too. So now we should be very careful while giving this intramuscular injection in the deltoid, because it is usually given in the lower half of the deltoid, the injection, to avoid injury to the axillary nerve. The axillary nerve basically lies under the cover of the deltoid in the upper portion. As we know, the axillary nerve winds around the surgical neck of the upper end of the humerus, and the upper end of the humerus lies under the cover of the deltoid muscle. There is a certain portion of the text given in the book that structures under the cover of the deltoid muscle. If you can read it, it will be for your good only. I have not included this in my slide. Okay, so now we come to the teres major muscle. This is a thick flat muscle which arises from the oval area on the dorsal or the posterior surface of the inferior angle and the adjoining lateral border of the scapula. So basically, if I have to say in a very short phrase, the teres major muscle, it takes origin from the lateral border of the scapula from the dorsal surface or dorsal aspect along the inferior angle. Now, insertion, as I said, medial lip of the intertubercular sulcus or bicipital group of the humerus. Nerve supplies by the lower subscapular nerve. This is, I think, a nerve from the posterior cord of the brachial plexus. Action is that teres major acts as a medial rotator of the arm at the shoulder joint. This is the deltoid muscle and this is the teres major muscle. Now the rotator cuff muscles. As I said, rotator cuff is quite important for you. And the rotator cuff is formed by 4 of the scapulohumeral muscles: supraspinatus, infraspinatus, teres minor, subscapularis. Now these muscles are often referred to as the SITS muscles, SITS muscles. It's a mnemonic, don't write it in this way. They form the rotator cuff around the glenohumeral joint. What is the function of this rotator cuff? Basically, the resting tone of these muscles acts to pull the humeral head into the glenoid fossa. So if this is the glenoid fossa, this is the humeral head, these muscles pull the humeral head into the glenoid fossa. This gives like this. This is the shoulder, stabilizes the shoulder joint like this manner. Posteriorly, it is not present. Anteriorly, superiorly, and posteriorly. Inferiorly, the rotator cuff muscles are not present, and that is why basically inferior dislocation of the shoulder joint is very common because there is no such support. So in addition to their collective function, the rotator cuff muscles also have their own individual action. This is the supraspinatus, infraspinatus, teres minor, subscapularis. Now origin, supraspinatus arises from the medial 2/3 of the supraspinous fossa of the scapula. Okay. Supraspinous fossa, I think you have been taught in the osteology of scapula. In the dorsal surface of scapula, the spine of the scapula divides the dorsal surface into a supraspinous fossa and an infraspinous fossa. So from the medial 2/3 of the supraspinous fossa, supraspinatus takes origin. Insertion, now I would also like to say this now only. Greater tubercle, there are 3 facets on the greater tubercle, on the posterior aspect of the greater tubercle. Superior, middle and inferior facet. This supraspinatus muscle is inserted on the superior facet of this greater tubercle of the humerus. In the middle facet, infraspinatus takes insertion, and in the lower facet, teres minor takes insertion. I'll come to it later. Supraspinatus is supplied by the suprascapular nerve, C5 and C6. I think this is also a nerve from the Erb's point. Okay. Actions, as I said, supraspinatus helps in the abduction of the shoulder joint, or abduction of the shoulder till 15 degree. Clinical testing, you can just go through this. Now, rupture of the supraspinatus tendon. It's a very common soft tissue injury in the shoulder region. So, if the patient is asked to raise his hand above the head, obviously the abduction of the shoulder from 0 to 15 degree will be affected because the tendon, supraspinatus tendon is ruptured. So, a common trick device that the patients adopt is that they raise the affected arm. For example, if my supraspinatus tendon is ruptured in the right hand, I'll raise this right hand shoulder with my left hand till the 15 degree. Okay, till 15 degree, and then from then on, deltoid will take over the abduction. Okay, but till 15 degree, with the help of the other arm, the patient supports the abduction function. Now, infraspinatus. It's thick triangular muscle which occupies most of the infraspinous fossa. It arises from the medial 2/3 of the infraspinous fossa by tendinous fibers from the ridges on its surface. So, below the crest or spine of the scapula, on the dorsal surface of it, there is this infraspinous fossa. Insertion, as I said, onto the middle facet of the greater tubercle of the humerus. It is again supplied by the suprascapular nerve, a nerve from the Erb's point, and its function is that it is a lateral rotator of the humerus. Teres minor, it's a narrow elongated muscle, and it arises from the lateral border of the scapula from the dorsal aspect or the dorsal surface or the posterior aspect. Now, the origin of teres minor is interrupted by the circumflex scapular artery, if you go through it, to go through the book. And it's the insertion of the teres minor muscle, it takes place onto the lower facet of the greater tubercle of humerus, as I said before only. Nerve supply, it is supplied by the axillary nerve, which is again, I think, a nerve of the posterior cord of the brachial plexus. Teres minor acts as a lateral rotator and weak adductor of the humerus. So here is very nicely given. This is a greater tubercle, and here there are three facets where supraspinatus, infraspinatus, and teres minor muscle takes insertion. Superior facet supraspinatus, middle facet infraspinatus, inferior facet or lower facet teres minor. And in the lesser tubercle, the subscapularis muscle will take insertion, as I'll come to it now. The subscapularis muscle is a bulky triangular muscle which fills the subscapular fossa. It takes origin from the medial two-thirds of the costal surface of the scapula. Costal means anterior surface, and the tendinous intermuscular septa that are attached to the ridges on the bone along the costal surface. Insertion. The fibers converge laterally into a broad tendon which passes in front of the capsule of the humeral of the glenohumeral joint to be inserted into the lesser tubercle of the humerus. This lesser tubercle of the humerus is important for you. Nerve supply is by the upper and lower subscapular nerves. Again, these arise from the posterior cord of the brachial plexus. Okay. Action is subscapular is the medial rotator of the humerus, and together with supraspinatus, infraspinatus, and teres minor, it forms a rotator of the musculotendinous cuff, and it helps in providing stability or support to the shoulder joint and holding the head of the humerus in the glenoid fossa during shoulder movements. This is the subscapularis muscle. This is insertion in the lesser tubercle. Its origin from the costal surface of the scapula. These are the rotator cuff muscles. This is the subscapularis, supraspinatus, infraspinatus, teres minor. Now the rotator of the musculotendinous cuff. The rotator cuff is a name given to the tendons of supraspinatus, infraspinatus, teres minor, and subscapularis, which fuse with the underlying capsule of the glenohumeral joint or the shoulder joint proper. The tendon of the supraspinatus fuse superiorly, tendon of infraspinatus and teres minor fuse posteriorly, subscapularis fuse anteriorly. The cuff plays an important role in stabilizing the shoulder joint, and the primary function of the rotator cuff muscles is to grasp the relatively large head of humerus and hold it against a smaller, shallow glenoid cavity. Here it's very nicely given. This is the anterior aspect, this is the posterior aspect. So anteriorly, it fuses, the subscapularis tendon fuses with the shoulder joint. Superiorly, the supraspinatus tendon. Posteriorly, the infraspinatus and the teres minor tendon. Rotator cuff tendinitis is a clinical aspect. Often tendonitis or tendinitis, as we say it. Rotator cuff tendinitis, itis means inflammation. Okay, so rotator cuff tendinitis refers to the inflammation of the tendons of the rotator cuff muscles. This occurs secondary to repetitive use of the shoulder joint. The most commonly affected tendon is that of the supraspinatus muscle. During this abduction function from 0 to 15 degree, it rubs against the coracoacromial arch. This coracoacromial arch is formed by the coracoid process of the scapula, the acromion process of the scapula, and the two connected by the coracoacromial ligament. So during abduction, it rubs against the coracoacromial arch, and over time, this rubbing or the friction action causes inflammation and degenerative changes in the tendon itself. Treatment of this rotator cuff tendinitis involves rest, very important. Analgesia means pain relieving medicines are given, okay, and physiotherapy. So these are the main three treatment. So, in more severe cases, steroid injections and surgery can be considered. So thank you. This will be the end of my today's topic. I hope you enjoyed it and you could learn something constructive from this video of mine.